mathematical analysis of infectious diseases, and she's a head of section at the Big Data Institute in Oxford. She's worked on intestinal worms, she's worked on HIV, she's worked on malaria, she's worked on influenza, and that's a list to which we can now add coronavirus. She's currently chairing a program working on different aspects of the COVID-19 virus at the Newton Institute in Cambridge. She's an honorary member of the School of Public Health at Imperial and has worked at the Zeeman Institute in Warwick and the Liverpool School of Tropical Medicine. So she combines both this wonderful theoretical mathematical approach, but always working within the context of the health professionals as well. So as an interdisciplinary mathematician who spent her career analysing disease, Deirdre is uniquely qualified to talk to us about the mathematics of lifting the COVID-19 lockdown. So there'll be plenty of opportunities for questions, but now I'll just hand over to Deirdre and thank everyone for being here. It's wonderful to see so many people.
Thank you very much, and hopefully you should be able to see my screen, and I'll start the presentation. Can somebody confirm that they can see that? Paul, can you see that? Have you been muted maybe? Thumbs up.
I can now,
Okay, brilliant. Yeah. Great. Okay, so thank you very much. I have to say I'm really gutted not to be in Edinburgh. I've had 2 fantastic trips to the ICMS and it's a real shame not to be there, but it's also a good thing that we're not travelling at the moment. So thank you very much for that kind introduction, and thank you to all the team at ICMS for all their work preparing today, and thank you all for giving up your time to sit on Zoom with us. So before I start, because often it's at the end and I think it's really important to thank people who contribute to this work. So I am basically summarising a load of work by a lot of other people, and so first of all I'll thank my research group listed at the top. I'm really fortunate to work with a really great group who thankfully ran through this with me yesterday evening, which was really helpful. And then I have a whole network of collaborators. I've highlighted some here that I've picked their brains from for this particular presentation, but there's a much longer list. And as Paul was saying, that's one of the joys of working on infectious disease epidemiology, is you get to work with a really broad range of people. And also a lot of what I'm saying is informed by, as Paul was saying, the participants of the Isaac Newton Institute programme on coronavirus modelling. And then most of my research is funded by the Bill and Melinda Gates Foundation, and I'm also supported by the Li Ka-shing Foundation, so I'd like to thank them too. Okay, so I thought I'd start with an audience question, and if you could type into the chat what you think the R rate is. Try and say it in your own words, and hopefully I can see the chat up here. So thank you very much, because there are some overlaps and some differences here, and I think it's important to pull them out because they're all overlapping concepts. So I just need to close the chat so I can see what I'm doing. So this is a more formal definition of the R rate, or the reproduction number. One of the challenges of our field is that people use rates for things which are not necessarily rates, which upsets some of the mathematicians, but we're going to walk past that one for the minute. So it's the average number of new infections caused by a single infected individual at this time in the epidemic. Okay, so it's if I was infected, how many people would I infect? Or in fact, if 100 people were infected, what would be the average number of people they would infect? And it's actually hugely variable between people, and that's why it's an average number. Now, there are some mathematical nuances here, and they're actually quite important, and there's a very relevant reference at the bottom of this slide. If you go and Google that, I don't think it's peer-reviewed yet, but it contains some really important points about the nuances of how exactly you calculate it. But I just want to give you a feeling in this lecture about what it is, why it's important, and some things that change it, and why during the lockdown it was well below 1, which is what we want to control an epidemic, and why different interventions will have different effects on it as we move forward from here. Okay, so who knows what the R rate in the UK is right now? And this time we're going to try and do a poll. Belle, I'm going to let you take over from here. Actually, it's probably represents some of the uncertainty about the reproduction rate, not formally, of course. So we do believe that the reproduction number in the UK is below 1 right now. So in fact, we've got an extra slide here if we move your poll out of the way for me. So this is from the UK government. The latest reproduction number is thought to be, I've got to move my screen again. Okay. So I'll go back a slide. So in the UK now it's 0.7 to 0.9 is the best estimate. And there's some evidence of regional variability, but other people would debate that. But that's kind of where we're sitting. So what do you think it was at the start of the epidemic? We've got another poll, Belle. Same numbers, which one are you going to vote for now? What was it in the UK at the start of the year? So this is also shows that you have picked up a lot of what's in the press. So most people have put between 2 and 5 effectively, and that is where the estimates sit. Again, there's some uncertainty. So thank you, Belle. If you close the poll, I'll put up another slide. So these are some estimates of the reproduction number in the UK through the epidemic. One is the one on the left is from the London School of Hygiene and Tropical Medicine, and it's this lower line here, and then here's it crossing 1, and here's the estimate from Imperial College London. I'm going to stop sharing that. Can everybody still see the poll? Yeah, I'll try and move it again.
I think it's away, the poll's gone now.
Okay, great, thank you. So here we have estimates from the London School, where this is 2, so kind of slightly below 2, and here we have an estimate from Imperial College, which is somewhere between 3 and 4. And the important thing to notice about this is obviously that it's bigger than 1, but how much bigger than 1 is interesting. We're sort of in the sort of 2.5 to 4 range. And one of the things we'll talk about later in the lecture is how important is that difference and how does it compare to other diseases. So just to review again, basic principle of infectious disease, a human-to-human infectious disease, which is what we're dealing with here, is that one person contracts the disease, they infect some other people, and they go on to infect some other people. And this is a scenario where you have exactly 3 people being infected each time in each generation. So you have an R0 or a basic reproduction number called R0 or R0. 0 is a slightly archaic English word for 0. It's called R0 because it's at the start of the epidemic. And that is telling us something about how many people each person infects. It's important to notice that it doesn't say anything about how long that takes, but we'll come back to that again later. If this number is bigger than 1, then we're going to have an outbreak, okay? On average, each person needs to infect more than 1 person for you to start to see an epidemic really take off. It's also important to realise that it is an average number, and this is a simulation from an online simulator for transmission trees. Each person does not, in fact, infect exactly 3 people. For example, some people will infect 1 person, other people will infect 4 people, and then we average it. And that means it's not a whole number. So even though it's based on the concept of how many people does each person infect, it is an average and it's not a whole number, despite the fact that Kate Winslet in Contagion only gives whole numbers in the film. It can be a number, so like 2.8, for example, was one of the estimates which was very commonly used for COVID-19. So why is it important? Why do epidemiologists go on about it? Well, it actually is a very key determinant of the epidemic growth rate. So you can imagine if each person is infecting 2 individuals, then the epidemic is going to grow more slowly than if each person is infecting 3, 4, 5 individuals. But the other important determinant of that is how long it takes for me to infect somebody else obviously affects the growth rate as well. R0 affects the timing of a peak and the sizing of the peak. And it also determines the effort required to control an epidemic. So if you're a long way from 1, you've got a lot of transmissions to squish before you get down to 1 and start to control the epidemic. And there are a lot of other factors that come into the control of an epidemic, like the proportion of transmission, but by proportion of transmission due to people who don't show symptoms, but by calculating R0 and calculating the proportional contribution of those different groups to R0, we can learn something about the epidemic. And so R0 is really a crucial parameter for us. So that's R0, but what about the R rate, which we're talking about most of the time now in the press? Well, it's R0 in a way during the epidemic. And the reason it's not the same at the beginning and throughout the epidemic is because at the beginning of the epidemic, no one is infected. And that's a really important part of the definition of R0. Once you get into an epidemic, some people have been infected. So for example, if I get infected early on in the epidemic, it's likely that my household has not been infected, and so I can infect all of them. But later on in the epidemic, there's a chance that the people that I live with have already been infected, so I can't infect as many people, and so the reproduction rate comes down. And the other main reason the reproduction rate comes down is because there are interventions in place. And so that's why the R rate changes through the course of the epidemic. I just want to do a slight aside about the role of modelling in the pandemic. So a lot of the understanding that we have about infectious disease dynamics come from a lineage of research which has been going on for hundreds of years. And the reason that mathematical modelling is part of epidemiology is that it is a tool for rigorising our thinking. When we develop a mathematical model of an infectious disease, all we're doing is taking the assumptions which are agreed with epidemiologists or clinicians, and we're writing them in a very rigorous way. So we're saying, this is how this infection is spread, this is how long it takes people to transmit the disease. And then we use the mathematical model to take that understanding to its logical next step in terms of how big will the epidemic be, how fast will it grow, what will be the impact of different interventions. And as such, it's a tool amongst many in our understanding of this pandemic. Importantly, it's not something we can just plug and play at the start of the epidemic. The scientific data changes through the epidemic, and therefore the modelling predictions, the modelling estimates are going to change as well. So through the SARS outbreak in 2003 and the pandemic flu in 2009, swine flu, for those of you who remember, we learned a lot about pandemics and about how infections spread. But this time is still different. We still have new things to learn. And I would say one of the things that's a real feature of this pandemic is a massively improved statistical methodology for estimating key parameters and providing forecasts on these global levels. I want to make one more note, which is in this talk, I'm going to focus on the transmission dynamics. I'm not going to focus so much about what happens to people after they get infected, why people have severe consequences, etc. We're really going to focus on why and how the transmission spreads, the infection spreads, and important drivers of that. So here's a mathematical approximation to the things that drive the reproduction number. There's three key elements. So let's say I'm infected with coronavirus and I meet someone. An important driver of how many people I infect is the probability that I transmit to another individual. And we're going to call that P. Now, if I am very likely to infect people, then I may infect a lot of people, but only if I see lots of people, if I have those contacts. So the number of contacts that I make is a really important driver of this number of infections that I cause. And that explains why we have different estimates in different populations. So it's possible that in some areas of the UK, for example, where people don't make as many contacts, social contacts, we would expect the number of infections to be lower than maybe an urban area where people are making a lot of contacts to whom they could potentially transmit. And also that different countries will have different reproduction numbers. And that's why we will see variance in the early stages of the outbreak and in the response to different interventions. And so we shouldn't assume just because something works in one population, it'll work exactly the same in our population. And then another crucial aspect of the reproduction number is the duration of time someone is infectious. If we think about something like flu, this might only be a day or two, but flu is very easy to transmit, and the sort of contacts that we make to whom we can transmit flu is quite high, and so the R0 for flu is relatively high. If we think about HIV, where people, before there was treatment, were infectious maybe for 10 years, the probability of transmitting per contact is actually low, and the rate at which people make contacts to whom they can transmit HIV is much lower than for flu, but actually the R0 values for some populations are similar for flu and HIV. And that's because it's all three of these elements that make up the R0 value. So what about for COVID-19? Well, we're gathering data all the time about infectiousness and the timeline team. One of the earliest pieces of information we had, and this really came from China, was that it was taking about roughly 4 to 5 days for people to become sick. So what we call the incubation period. So that's the time from when I get infected till I show symptoms. It is around 4 or 5 days, but there's quite a long tail out here. And there were reports of people taking maybe 14 days to get sick. And that's why we see guidance like a 14-day quarantine period for some countries for incoming cases, or a 14-day quarantine period if you're identified as a potentially infected contact. That's because if I just contracted coronavirus at the point of, say, getting on a flight or on the flight, it might take as long as 14 days before I were to get sick. And that's where those kind of guidance come from. The data, again, is improving all the time, and we're learning more and more that the peak is really probably around this 4 to 5 period, but there are still some cases of quite long incubation periods. The other piece of information we have is how long it takes for people to become really very infectious, or how long they stay infectious. And this is an unusual feature for coronavirus. There's a lot of this weight of this distribution is before people show symptoms. Okay, so here's the day on which people show symptoms, and we have some evidence that viral loads and some transmissibility occurs before this time. And then that is really quite challenging for control. And then this is some data, which is if you know when somebody was maybe showed symptoms, and then when the person they infected got symptoms, actually I'm not sure which one this is, you can, so if I get networks of people who infected each other, I can learn something about these timescales. So we're looking, if we think about SARS, for example, which was the closest virus that we knew about before the start of this outbreak, these sorts of timelines are similar, the time until you get symptoms, but this is really different. This is much more like flu in terms of having pre-symptomatic infectiousness. And that has important consequences for control. This is some work which was done by Christoph Fraser and others prior to the after the SARS outbreak, where they tried to understand why SARS was relatively easy to control. So here we have SARS, where we had an R0 around 3 to 4, so we're kind of in the same ballpark as the current coronavirus. If we think about something like smallpox, it had a much higher R0. At that time when this paper was published, the R0 for flu was thought to be very high because it was mainly informed by one study in a school, a boarding school. Now we would really put this down around 1 or 2. And HIV, where the R0 is probably around the 2 to 4 mark at a population level, will be different in different populations. But the really important insight here is what proportion of transmission occurs before people show symptoms. And for HIV, in untreated HIV, they raise a little bit of symptoms when people are first infected, but really the main symptoms are AIDS, which occur many years later. And so the vast majority of HIV transmissions occur before people show symptoms. Whereas with SARS, the vast majority of transmission was occurring when people were symptomatic. And the reason that's important is that if you just isolate people with symptoms, you can control the outbreak. And in this paper, there's a mathematical approximation to how the relationship between R0 and pre-symptomatic infectiousness affects contact tracing and isolation. But the important thing to remember is that diseases for which very little transmission occurs before symptoms are much easier to control using symptom-based isolation, etc., than diseases for which symptoms and infectiousness are not very well aligned. I should mention at this point, so we think that coronavirus sits around sort of 2 to 3 level in here. Where it sits on this axis, and the reason I haven't put it on, is actually very uncertain, because there are 2 aspects of transmission without symptoms. One is pre-symptomatic transmission, which we think is quite a lot, and then there's asymptomatic transmission, so people who never get symptoms. And just, I think yesterday or today, the WHO released some guidance saying that they thought the proportion of people who were asymptomatic was a lot smaller than initially thought. And so that's really an area of active research. I think there's going to be quite some debate about that, about which data sets are the highest quality. But if there is a lot of asymptomatic transmission, then where the sort of symptom-based control is not going to be so effective. And in particular, contact tracing based on symptoms or isolation based on symptoms alone is unlikely to be enough to control the epidemic. But as I say, this is a really important parameter which there is some uncertainty about. Okay, so that's sort of telling us something about the probability of transmission and also the duration of infection during which you could transmit. What about this probability of transmitting from person to person? We can, of course, reduce this doing things like washing our hands and wearing masks or social distancing. And this has really changed over the course of the epidemic. And the messaging around hand washing is still really important, and social distancing, as we think about coming out of the most extreme levels of lockdown. We still need to consider the fact that someone we meet may be infected, or that we may be infected ourselves, because there is asymptomatic infection. And one of my colleagues said early in the outbreak, we have to act as if we're infected. We have to act as if we want to protect the people around us, as well as protect ourselves and protect our own households. So this is a part of our behaviour which we have some control over. What about the C, the contact rates? We have very varying numbers of contacts, and this has been studied for many years through contact surveys in particular. So these are surveys where we ask you, how many people did you see today? How many did you see yesterday? How many of them were known to you? How many of them did you see, every day for the last 10 years, for example? Or how many of them are people that you work with? And how many of them are people you couldn't possibly name, but you sat next to them on the bus? And we can think about our contacts in terms of how long we talk to them, whether we have physical contact with them, and how far we stand away from them. So Matt Keeling and John Reed and others at the University of Warwick have conducted one of these surveys a few years ago, and the data is freely available, where they have one of the best sources of information on heterogeneity in contacts by occupation. And so you can see here that they have some really quite different contact networks for different people. And in terms of the definition of a risky contact, for this study, they used 3 meters as their definition of a contact, but then they stratified them by whether it was more than 15 minutes contact or less than 15 minutes contact. And this is a schematic drawn by John Reed, thinking about people who you do have close contact with, people you have more distant contact with, and who you are more or less likely to infect, and then who you are more or less likely to be able to identify. So I'm going to jump out just for a minute. So as a consequence of the fact that contacts are crucial for spreading infectious diseases, the main aim of the lockdown was to reduce the number of contacts that we made. And this is a great website by these authors, in particular Martina Morris, trying to address the question which a lot of teenagers and a lot of us had, which was, can't I please just visit one friend during the lockdown? And they used some network modelling to explain why that's really not a good idea during a full lockdown. So here they simulated a network of contacts. And here you can see everybody is well connected through the people that they know. Each individual doesn't have that many contacts, but we all become connected in a network. And here's what we think happened during the lockdown. We're in perfect isolation. Each individual is not contacting others. In this particular simulation, they haven't got households, they do in one of the later ones. Okay, we know there are some people who are essential key workers who had to have some contacts. And you can see the network changes. You start to see key workers linking different groups of people potentially in transmission. And this is why it's so important to provide personal protective equipment to key workers, because they can form this linking behaviour in transmitting infection to other people and putting themselves at risk, of course. Okay, so what if an average of 2 people in each household decide to maintain an in-person social connection with one person from another household? So the assumption is here that they don't socially distance from that individual. Okay, now our network has suddenly become much more connected. So just by a few people having those extra contacts, we're actually connecting up the network, and much more people are at risk if an infection was introduced into this network. And what about if you do it just one friend per household? Now, it's not quite as well connected, but still there is a good level of connection in this network. So if I go back to my presentation and see if I can, there we go. This is one of the things we need to really be careful about when we come out of the lockdown. We've been incredibly effective at reducing our number of contacts. And as we start to increase our number of contacts, we're obviously going to use things like hand washing and social distancing, and to some extent masks, to prevent the probability of transmission when we see a contact. But we still need to remember that we are a social network, and our behaviour puts other people in that network at risk. And that's why it's important to consider your behaviour over the next few months and consider how you behave when you make those new contacts. We are social beings. We do want to see people. We just were talking about the fact that we miss seeing people face to face. But do consider how you behave for the rest of the people in your social network. And I'm just going to make a passing comment about bubbles and point you to work at the London School of Hygiene and Tropical Medicine and at the University of Warwick about bubbles. Bubbles can segregate the network again, but obviously you need to be sure that your bubble is secure. And so you need to trust the people in your bubble that they're also respecting the importance of hand hygiene, etc. Okay, so I'm nearly done. I'm just going to say only a few words about R is estimated. So the reproduction number is based in reality in a real tangible thing, which is how many people does each person infect. But unfortunately, it's almost impossible to directly measure. And that's because we don't know exactly who is infected and we don't know who infects who. Therefore, we have to use the available data to estimate it. So here we have, and this is from my first slide, we have the number of cases of coronavirus diagnosed in the UK over time. And the way that we estimate the reproduction number is we say, okay, well, let's consider each individual at this point of time who's infected here. Well, they were tested then, but they probably got infected back here. Okay, now we're looking back at this point in time. Which of these people were infectious at that point in time? And therefore, and which ones of them were more or less likely to infect that individual, given the infectiousness profile that I showed in one of the other slides? And from that, we can estimate the probability that any one of these cases infected the case that we detected over here. And then we can build up a picture over the time, which is over the time here of the epidemic, of who is most likely to have infected who. And then from that, we can calculate the reproduction number. And as I was saying earlier on in the lecture, there's been a real step forward in terms of statistical estimation here, because there are key uncertainties in the time of infection relative to the time of detection, and also the unseen cases. And so I really recommend there's an extensive literature on it. And I also recommend that paper earlier on about the subtleties and how you define it and how that impacts what estimates you get and whether or not it's below 1. So I'll finish with this slide, which is, where do we go from here? This is the work that we did early in the pandemic, talking about what an unconstrained epidemic might look like and what an epidemic with some degree of social distancing might look. And the word of the moment was flattening the curve, so lowering the total amount of infection and pushing it out to the right, so making the peak later. What actually happened is that we got the reproduction number below 1, and so therefore we had important drops in the number. This is real numbers of underlying new infections. Of course, detected infections and things would follow a slightly different pattern. And although we wrote this in March, the question is still, will we get a resurgence when we lift interventions? And that remains to be seen. But as I've described in this lecture, there are many different facets of our behaviour which are changing and which will change the likely outcome of this outbreak. So we have things like contact tracing, which are designed to identify infected individuals and stop them spreading on. So that's reducing that P, the probability of transmission onto others. And we have all of the different changes in our contact patterns and the probability of transmission per contact, So there's good reason to believe that we are not in the same place that we were at the start of the epidemic, but there's still a lot of uncertainties about what exactly is going to happen now and which interventions will be most effective. But we have so much to learn from all of the other countries which are going through the same thing, and also through our individual behaviour. Over the next few weeks, the government will learn a lot about how we're likely to respond to a lifting of restrictions. And so we will see what happens. I'm afraid I don't have an answer, and we will see what happens to the reproduction rate. But it is a useful tool for understanding how close we are to starting a resurgence and responding to it. But it's only one of many data streams which are going to be used for making decisions. So I'm going to finish there. Paul, if you would like to ask any questions or take any questions. Thank you very much.
Well, thank you very, very much, Deirdre. I'm going to do a clap. Everybody else can do jazz hands, you can do emojis, you can do reactions, you can do thumbs up, you can do all sorts of things, but thank you very much. So I'm going to start actually. There was a very nice question early on from Patrick, which I think goes to the heart of what you were talking about without getting technical at all, which is a very good place to start, which is, do models have a good record of predicting past epidemics? I mean, how much should we be reading into this sort of thing?
So I think there's two aspects to that question. First, statistical short-term predictions are often best done by statistical models, by which I mean curve-fitting models, which say, where is this curve heading? Where is it likely to go? So in that kind of test, our sort of models, transmission models, are actually not always that good. But you need them in order to understand the role of different behaviours, for example, on the transmission dynamics. And so you need that kind of model to say, well, if we did this, if we reduced contacts by half, would that be enough to get us there or not? And then models tend to be used then to make qualitative predictions, like we think this will be enough to do that, or we think this is what will happen if this changes. And that's almost never testable. So because people's behaviour changes through a pandemic, it's not that testable. So I would say we have still things to learn. And yes, I'd say that models are incredibly useful in live policy decision making, but whether they are the best possible way to do a short-term forecast is debatable. But for the long-term behavioural predictions, they've been shown time and again to be incredibly useful, I would say. But it's debatable, I would say also. Yeah.
Yeah, so a question also quite early on from Serish Shah, which was asking about how SAGE manages, I mean, or just modelers manage, to deal with the fact that the R rate can be UK-wide, regional, in schools, in workplaces. So how do you interpret an R rate versus several R rates?
Very good question. So it's not simple, and there's a really nice online tool on a mathematical education website called Plus something, maybe Paul or Dawn know it, but we can find it afterwards. It is actually really confusing to have multiple R rates, one in schools and one in homes and one in hospitals, for example. It's not simple to interpret those, but they're still useful depending on what policy question you're asking. So if it's a policy that's going to be UK-wide, you might say, well, I need to know the R rate at the national level, and then you might understand how that affects different parts of the country. If you're looking at our hospitals a problem right now in terms of transmission, then you want to know the R rate for hospitals. The UK-wide one is not that useful. And so it really depends which question you're asking. But I think it does pose an interpretation problem for the public.
So who asks that question? I mean, when do you decide which R rate do you use?
So I've never been part so far of the UK government process, so I will comment from the outside. In my experience with other diseases, it's a policy. It's really particular policymakers have particular questions that they're interested in. So it tends to come from a particular policy need, and different stakeholders have different questions. So if I have for the diseases I work on, the World Health Organization may have different questions to somebody who controls that disease in a particular country. And so we try and address the question which is being asked of us.
So now moving on to the bit about connectivity and networks, Colin asked, look, Colin says, so school bubbles are not actually bubbles, because you were talking about bubbles as being, you know, totally hermetically sealed in some sense.
Mm-hmm.
So when we're talking about coming out of lockdown with creating bubbles within schools, obviously there are connections into families and so on. So mm-hmm. how does that influence the way that you look at that sort of lockdown exiting strategy?
So the bubble includes the families really that sit around those school children, right. I would say. So, but there's also an issue in schools of trying to bubble them so they don't have too much interaction with other school children, so that you try and reduce transmission in the school. So that's the purpose of those bubbles. So you try not to have those different children in the same place at the same time. And so that's to try and reduce transmission in the school. But then that then affects the families outside the school. So you also don't want the families bringing infection into the school either. So, you know, we're all connected. You want to try, the schools are very keen to reduce transmission in schools, and so they're setting up a system by which they hope to reduce or even prevent it completely. And then we as families then try and look after our families and our children and the children in our schools.
Mm-hmm. So there's quite a lot of questions coming through about strains and variability in the virus and evolution of the virus. So, you know, questions like, you know, if we slow the thing down now, does that just give it time to become sort of a more powerful or virulent virus? On the other hand, thinking of it as being related to things that we've seen before, is it possible that there's a natural immunity because of that? And how would you see that in the data?
So this is not my area of expertise, so I'm going to caveat everything I say with that. So I'm going to share with you what my understanding is. Mm-hmm. So my understanding is that this virus actually evolves quite slowly. There is variability between people, so we can see that people have drawn genetic trees where they can see that there are different strains of the virus, but actually there's not that much variability between them. And the reason that is important is I think it's quite hard to say, you know, if I infected you and you infect somebody else, that we couldn't really necessarily, as I understand it, from the amount of variability we see, we couldn't necessarily say the direction of transmission. So in terms of other viruses which evolve more quickly, as I understand it, evolves a lot more slowly than, for example, flu or HIV within host. And so in terms of timelines for a more virulent version of the virus to evolve, I understand that we're not in that scenario yet. I'm not saying it's not going to evolve over years, but so far, and again, I caveat it again with me not being an expert, so if there's a more expert person in the audience, I'm happy to take their viewpoint. That's not the primary concern at the moment, a more virulent virus. That's not to say it couldn't happen, but that the evolution seems to be reasonably slow.
So that's sort of good news for if there were a vaccine, that it might actually be effective for a reasonable amount of time, rather than say flu, where you have to change the vaccine every year.
Yeah, I believe that's the hope, absolutely. That we would be in a quite different situation than a flu vaccine.
So sort of moving on, Jane from ICMS, hello Jane, asks, you know, you were talking about things where you're modelling for different countries. So for somewhere like Germany, where they had less stringent lockdown but far fewer deaths, is it at all obvious in the modelling why?
So that can be a combination of different things. So one of the things which of course has been debated in the media at the moment is the time at which you intervene. So for example, Italy was arguably unlucky in that it had a lot of cases very quickly, and other countries had more time to react. So countries were different in when they were able to react, simply because of cases that they had. Some countries, the public behaviour changed more quickly early on in the outbreak as well. Some countries were better at detecting cases, and you know, there's just a huge number of variables which can determine it. I actually haven't looked at the reproduction numbers estimates for Germany, so I shall go and have a look on the London School website. But I suspect it's a combination of those factors. So there's some kind of population specific contact rate. There will be the timing of when the virus was introduced or repeatedly introduced to Germany, and when the responses started in terms of behaviour and then any enforced lockdown.
And Nikesh, hello Nikesh, asks, what can we say about the quality of the data we have on COVID-19 now? Because you were talking about everything evolving with the data, but how confident can we be about the different ways that we're seeing things in the modelling and the way the data is sort of working with that?
So I think there were early challenges in terms of just detecting cases and confirming cases, and it seems that testing rates globally have improved, and that is giving us a lot more information. It's giving us information about asymptomatic and pre-symptomatic individuals. It's giving us information about who's transmitting to who, and also the serological information. So that's where we have a test based on antibodies, where we can see whether you've had the infection in the past. That's really allowing us to constrain our estimates of R0 and the epidemic growth rate. And so there was recently a study that came out amongst blood donors in the UK, which suggested that the number of people who had been infected in London was, I think it was about 17%. And that suggests that, you know, it was a reasonable sized outbreak in London compared to the rest of the UK. And that information is really useful for constraining some of our estimates. So there's no doubt that our understanding of the virus is progressing very rapidly as these new data streams come online.
So again, a question about R and interpretation of R. So A. Mikeson asks, if an infection spreads until herd immunity is reached, so there's a question there about what herd immunity is and so on, does R still have a useful interpretation? So what's the relationship between an R number and what the disease is actually doing within the population?
So if you can still see this graph that I have in front of me, the red line is an unconstrained epidemic. Okay, so what happens is that there's no interventions, nobody changes their behaviour. The epidemic grows and grows. And the reason it turns over is the thing I was talking about earlier, the fact that you get saturation in the network. So if I'm infected around this stage in the epidemic, I can't infect that many people because the people that I know have already had the virus and they can't get reinfected. One of the questions is, can they get reinfected later on? But for the moment, let's assume they can't get reinfected. And actually, if you were to plot the reproduction number through this epidemic, it would start to cross 1 around here. So it would start, Arnold, I think for this simulation is about 3, sorry, up here, and it starts to decline through the epidemic as this saturation effect starts to happen. And so R is still a useful concept in an unconstrained epidemic and in an epidemic with herd immunity. So this is often described as herd immunity here, because if you restarted the outbreak along here, you wouldn't be able to start it off again. Epidemics always overshoot the herd immunity threshold. So you do get more people infected in here than just the herd immunity threshold, as in the proportion of the people who have to be protected for you to not have an outbreak. But the reproduction number is still useful. So if there is herd immunity, then the reproduction number is below 1, and you can estimate that from the small numbers of outbreaks that you would get. There's some great papers on estimating the reproduction number for measles from the size of outbreaks in the 90s.
Thank you. And Gerda is asking how much the population would have to be following contact tracing for that to be an effective strategy to reduce the spread of the virus. So how important, how is this going to work out and what needs to be in place?
So there's a lot of preprints have come out recently in the UK and elsewhere, looking at the efficacy of contact tracing and what are the key determinants of it. I would say the majority of them say that contact tracing can only work alongside other social distancing measures, because contact tracing on its own is not going to be enough, because contact tracing is probably based on symptomatic cases, and it depends how many asymptomatic cases are out there. And then it requires a good test of the people who are contacts of that individual, and the test is not perfect. And then it requires that all of those people are quarantined or isolated for quite a long period of time. 14 days is quite a long period of time. And while there are different features in different countries, that's generally the message, I think, which the modelling is saying, that there is some nuance to when and where contact tracing will work, depending on exactly the details of the protocol and the quality or otherwise of the test that you're using. and whether or not it's used alongside social distancing. So contact tracing is a really important tool, but it's not going to be a panacea, I think.
And where do things like I mean, you know, there's a lot of debate at the moment over the 2 metre versus 1.5 metre versus 1 metre social distancing. Where does that fit in your modelling, and you have a view on it?
So again, I'm not an expert in that data actually. So what I will say is that we know that the social distancing at the moment is working, but that is really quite an extreme form of social distancing. And what the models will allow us to evaluate as the new data comes in is to what extent the social distancing is continuing to work. So there will be ways to estimate the reproduction number over the next few weeks, which will tell us about that. But this 1 metre versus 2 metres is really dependent on the dynamics of droplets, which I'm unfortunately not an expert in, but obviously you can imagine that the distance affects that. And I'm sure they're doing lots of studies. I'm sure, again, we're going to get a lot more data soon about that.
In time?
Sorry?
In time? I mean, you know, in order to actually implement something, it has to be in time for it to be sort of useful. So do you have a sense of how the science and the policy and things are working together?
I think for this one, and I because I'm not closely involved in it, I can probably comment more freely, which is, it's always a question of how safe do you want to be. So, you know, 2 metres is presumably at the end where you say, okay, well, and again, I'm not an expert, let's assume that it says, okay, this is really unlikely that you'll transmit to somebody at 2 metres. Whereas at 1 metre, obviously, there's some probability that you will infect somebody at that distance. As a policy decision, it needs to be, well, what's the value of that probability that I'm happy to take? Is it 1%? Is it 5%? Is it 50%? And so, but the quantification of that value is probably pretty uncertain. And so it's, you know, it's going to be a policy decision over what threshold we're happy to take and how confident we want to be that we're at that threshold. So as always in these types of policy decisions, it's a judgment call, and it'll be driven by public feeling as well as scientific data.
So Veronica Biga, hello Veronica, is really asking a general question on, as an individual in a wave, what's the riskiest moment for you?
That's a good question.
Is it actually when it's, yeah, so.
I'm afraid that depends where you are in the network. So it's more your network, I'd say, that would determine your risk than necessarily the timing. So the time at which it gets into your network and how well connected your network is, that will is what I think you should consider more. I mean, in terms of the UK epidemic at the moment, there's definitely very low numbers of cases at the moment. So in some sense now is a relatively safe time in compared to the last few months. But because we can't see the infections, we can only see the cases and then the hospitalizations. When it starts to change, we will have trouble identifying exactly when it's changing. So you should be precautionary in your behavior.
So, sorry, I think it was David, I've lost the track, was...
I have to say you're doing very well, Paul. It's hard reading like 40 questions. So.
I'm both reading and listening well.
Yeah.
Impressive
skills, yeah.
Sorry, I'll get there in a second. So David Nichol asks, is it possible for the UK to be like New Zealand and all but completely eliminate the virus? I mean, what do you think the end game is going to be here?
Really interesting question. Yes. Is it eliminable? And under what conditions is it eliminable? So if we think again of this blue curve, you know, how close are we to zero and what would it take to get to zero? And then if we did get to zero, what would be the risk of reintroduction? And if there was a reintroduction, what would be the probability of a really large outbreak rather than a contained outbreak? All excellent questions. And I suspect from what will happen in the UK over the next few months, given that there's been some lifting of interventions, we'll understand what it takes to maintain it at a lowish level, and whether it is possible to contain at a low level. And other countries may be trying to eliminate completely. But again, it's a political decision because it has a huge economic cost in the UK to get us here, social and economic cost. and it would probably take another huge social and economic cost to get us absolutely to zero. And then we'd need to be sure we weren't going to get it reintroduced, and with all of the economic cost of that. So I'm afraid we're going to learn over the next few weeks and months what this in-between ground looks like between before March and the lockdown. And we're going to learn what we can maintain and what we can contain. And maybe we will be able to eliminate it locally in the UK, we shall see. But it seems to be quite challenging.
And so another David asks, I think this is an interesting one. If you could wish for one key piece of information at this point in time, what would it be? What would make the biggest difference to the way that you feel that you could sort of describe what's going to happen next?
Testing, understanding this asymptomatic question, the WHO coming in support of this systematic review, saying that actually a low proportion of people are asymptomatically infected, is an interesting one. So I think that is quite important, although we have other sources of information for that. And then just, you know, if you had a magic wand and could test everybody and find out whether they had it or did have it now, you know, but that's not going to happen. So that would be impractical. So yeah, I think this asymptomatic question, which we should be able to get at through the contact tracing. So contact tracing is not only an intervention on its own, it's actually a really powerful source of information, because you find out at the point when you find someone is positive, then you find out who they've transmitted to or not. You understand how long it took them to transmit to other people. And then the people who you follow up, you find out whether they're asymptomatically infected or not. And so contact tracing, I think, is going to be a fantastic source of information as well as an important control strategy.
Do you have a sense of why the asymptomatic question is still such a question when people have been looking at this so closely for so, well, and not so long, but, you know, it's been a major issue over the past 4 months across the world?
So a great paper came out a couple of weeks ago from Johns Hopkins, which shows how the test positivity changes over time. And so
what's that mean, test positivity?
Good question. So if I'm infected with coronavirus and I do a test today, I'm not going to test positive even if I am infected, because there's such a small amount of virus in my body. But over time, I start to have more virus and then it drops away again. And so the probability that I'll test positive by a test is changing over time because the amount of virus in my body is changing over time. And so then that creates great uncertainty about data which just tested me once and said I didn't have infection or that I did have infection. And that causes great challenges for interpreting that kind of data.
Yeah, I can see that.
And there's also the issue that if you tell me that I've got coronavirus, I might be more aware that I had symptoms, when if I didn't know I had it, I might have said I didn't have any symptoms. But that's one of the big challenges with asymptomatics as well.
So Nicholas Tucker is asking, really, what is a super spreader? So we see this in the newspapers this term. So what is this, a behavioural? Is this a physical? What's underneath that? And then there was a question earlier which I didn't pick up on, which was saying when you were calculating the R values, where's the variation in the population, for example, the super spreaders, come into that?
So these days we talk about super spreading events in order to reduce the stigma on the individual who is at the centre of them. So super spreading events occur exactly as you're saying for all of those things. So it could be behavioural, so it could be an individual who happens to have a lot of close contact with a lot of individuals. It could be just contextual, that somebody happened to cough on exactly the right thing, which loads of people touched immediately afterwards and happened to immediately infect themselves. It can happen for a lot of different reasons. It's a feature of every epidemic, always the same. So Ben Cowling gave a talk at the Isaac Newton Institute a few weeks ago and said that from their data, as is always the case, roughly 20% of the people are responsible for roughly 80% of the cases. And it's a feature of every epidemic, and it's a mixture of sort of behaviour and circumstance. So on, for example, if you could have a super spreading event on the one day that somebody happened to, for example, go to the supermarket or sing in a choir, whereas if they'd sung in the choir 3 days earlier when they were just infected, they might not have infected anybody, because their infectiousness changes over time. So,
so this comes back to sort of question, last question, I think, because we're running out of time. But Tim Gardner, right at the beginning, was asking questions about the time lag on calculating the R0 and the question about the variability, the super spreading events and things like that. So when we talk about R0, it's a very crude thing. Are there models where you use an envelope of R's, or how do you get over the sort of thing, and how do you get over what Tim was talking about, the time lag?
So absolutely, these estimation methods account for that possibility that, you know, it's a very wide distribution in terms of the number of people that they can onward infect, but then they take this average. So the time lag is kind of a separate issue. So the two things combine to make it quite a difficult statistical problem to estimate the reproduction number, and that's why different methods may give you slightly different numbers, and that's why it's an area of active research, because we've never had exactly this problem before.
Right, well, I think we're coming up to 5 and we ought to let you go.